I'm Hari Naidu, and welcome to SCAI-TV at SCAI 2018 Scientific Sessions. I'm joined by Dr. David Kandzari, an expert in the field in antiplatelet therapy.
Thanks for having me.
We're here to talk about short DAPT. So the question first is, why short DAPT? I think for many years we were trying to get shorter and shorter DAPT, but there's more and more data that, of course, in some patients with higher ischemic risks, or even in the baseline ischemic risks, it might be beneficial to prolong DAPT.
It's interesting, hasn't it, that we've come full circle in the evolution of drug-eluting stents from the initial introduction of Cypher and Taxus, which actually came with relatively short dual antiplatelet therapy durations, longer than a bare metal stent, but relatively, 3 months, for example. Then after our FDA panel meeting in 2006, in which I participated, the mandate clearly was for 1 year. And there was no magic around 1 year.
There was no data.
It wasn't like 364 days was bad and 366 days was great.
In fact, the data was more for after 1 year.
And to that point too, it was based largely on pharmacologic trials, pharma strategies, rather than specific to stent thrombosis or drug-eluting stents. And that mandate has really persisted through guidelines, especially more in the United States than in Europe for years, and it's persisted as a standard of care in clinical practice. And now, just as you imply with the successes that we've observed with contemporary PCI and in part contemporary drug-eluting stents, we see not only exceptionally low rates of target vessel-related myocardial infarction and stent thrombosis, but it's also in part raised this issue of the safety, which is very favorable with existing drug-eluting stents, and is there a need for longer-term dual antiplatelet therapy? It's raised this balance of risk versus reward of bleeding, and then further, I think in many ways in the evolution of interventional cardiology, whether it's CHIP or complex intervention, in part comes along with that a growing population of elderly patients, of high-risk bleeding population, of novel oral anticoagulants, and the combination with dual antiplatelet therapy. So it helps us lower the bar a little bit. So now we're driving this focus towards shorter dual antiplatelet therapy, and as trials evolve, and we can talk about that in a moment, the other issue is ultimately what is the optimal short duration of DAPT. As you know,
well, we got used to 1 month with bare metal. People would love 2 weeks to 4 weeks. I mean, back in the day, people would use 2 weeks every once in a while. And
part of the issue too has been in the design of shorter dual antiplatelet therapy trials, at least in the United States, there's been a regulatory reticence, and at least initially, for moving down to the 1 month time period, maybe starting at 3 month time periods, which is existent in the Evolve DAPT trial. And now other manufacturers are moving forward, for example, Abbott with the Zion stent, Medtronic now moving to the 1 month dual antiplatelet therapy study. And the other challenge too is how you go about designing these trials, not simply in is it randomized or not, but really what data can you leverage to formulate your estimates of event rates, for example, your hypothesis. Most of these trials, if not all of them, as you know, are done performed in a high bleeding risk patient population, and that in itself is an evolving nomenclature, because what's high risk bleeding in one trial isn't necessarily the same.
I guess the question, does it have to be in a high risk bleeding population or low ischemic risk population?
You know, that's at least the low-hanging fruit, it seems, or for patients who maybe have also a simultaneous oral anticoagulation requirement. I think ultimately the takeaway from these trials, and hopefully they're very successful, will be that it's not that everybody who is high bleeding risk per se should just get 1 month or 3 months, whatever was studied in the trial, but that what is the acceptable minimal duration of dual antiplatelet therapy that preserves the safety with it as well. And I think also that right now, that as we see newer drug-eluting stents enter into the U.S. marketplace, this is going to be even more formative, even more an evolution. When we initially thought about proposing a trial with the Endeavor stent in approximately 2005 with short dual antiplatelet therapy to the Food and Drug Administration, and this was prior to the DAPT trial was being formulated, we were looking at sample sizes, we were looking at trial designs, and I think we were even thinking about something like a 3-month duration or a 6-month duration. But even when we thought about that at the time, the thought wasn't that it was for everybody, but for
A subset of the population.
A subset of the population.
Yeah. Well, there's no question that there are some patients, patients who might need surgery soon, or patients who have unknown bleeding risk, cancer patients or whatnot. This would be beneficial for us. So I think there's a lot of exciting things to come.
Related to short dual antiplatelet therapy too, and just as you say, for the patients requiring more urgent or semi-urgent non-cardiac surgery too, is this concept then of the safety with existing drug-eluting stents. And that part, I think we have a great deal of reassurance with. In an editorial I wrote some time ago, it was entitled "Can't Bear It Any Longer." That there's probably no role for bare metal stents.
Yeah,
that's still used in about 10% of U.S.
I'm always surprised
today.
when I see those numbers, because I haven't used one in a long time, and that's just my own practice. But I think getting over that thought that bare metal must be safer, I think, has taken some time. But I think the data does bear that out.
As we move forward, though, at least in U.S. practice, for the evolution of guidelines documents, my expectation, and I don't know about your thoughts, is that it'll still be largely preserved for the higher bleeding risk population. We've now in the United States completed a trial with a polymer-free drug-eluting stent in that indication as well. That's really where the existing and forthcoming clinical trials are going to be. The issue, as I mentioned, too, for newer sponsors of drug-eluting stents that are coming in the United States will be what data do they have existent in their data sets, in their warehouses, to justify a single-arm trial. Will they need to do a randomized trial? And the regulatory dilemma in the United States is there is no drug-eluting stent right now that has a 1-month or 3-month indication.
That's
so what is the comparator as well?
Well, I think clinical care, what we want, moves faster than the regulatory, and which is more risk averse. So.
Absolutely, it outpaces it. And then as another small aside, and this is what we're currently permitting in the global randomized trial with the Resolute Onyx stent, is when you do switch to a single antiplatelet agent, which agent
one
is it?
Oh, that's a whole different discussion. We have to bring you back for that.
Yeah, that's being studied in another large trial with ticagrelor, but we allow investigators to choose that. Most commonly it's aspirin, but that may not be the right decision as well.
Right. Well, thank you for coming. Fascinating discussion.
Thanks
I think
for
there's more
having
to come in this field.
Absolutely.
Thank you for joining us for SCAI-TV at SCAI 2018 Scientific Sessions.